Hello and welcome. Thank you once again for joining me on Carroll PMC's video interview series. I'm excited to have you all with me today as we discuss another's journey through medicine. And today, I have a great guest speaker for you all, Dr. Aaron Wernham. He is the Montana Healthcare Foundation's Chief Executive Officer. Prior to this position, Dr. Wernham spent some time servicing underserved communities in California's urban and Alaska's rural areas as a family medicine doc. He received his medical degree from the University of California, San Francisco School of Medicine. And he's an excellent physician. He spoke about different aspects of family medicine, different aspects of servicing different communities, and the differences between those communities, both urban and rural, and many different things regarding how to impact change on a policy level as a physician. So let's jump right in and say hello to Dr. Wernham. Dr. Aaron Wernham, welcome to Carroll PMC's video interview series. It's great to have you this morning with us.
Thanks so much for having me. I look forward to talking with you, Andrew.
When did you realize you wanted to become a physician?
Yeah, so your question that you sent me made me think back to that. I think it probably took place over a few different periods of my life. My mom had a couple of pretty serious illnesses and a couple of major surgeries when I was in elementary school, and I remember, being terrified, but also that the whole process of surgery was really fascinating to me, and just learning what they were doing and being kind of amazed that they could do that kind of thing was, I think, fascinating to me. I was one of the kids, that always loved science in school. So I think those two probably prepped me for this path. But then I took some twists and turns. I actually dropped out of school when I was 14. Spent a long time kind of as a rock climber and carpenter, and through that period of time had a few sports injuries, and also a climbing partner who was an orthopedic surgeon who kind of helped me through one of those, and I just never lost the love of science through that whole time, and just started thinking, at some point I'm going to want to come in from the outdoors and do something different with my life, and so I think it was when I was probably about 20 that I made the decision to get back into school and try to be a pre-med.
That's interesting. I'm curious. You said you went and did a little bit of climbing.
Yeah.
And I'm curious what those experiences taught you as far as what brought you back to medicine. Because climbing is awesome. I've done it a few times myself here in Montana. It's great. But I do some running too, and oftentimes some of the hardest races I've had have really recertified myself on the difficult path towards becoming a physician. I'm curious if climbing did that for you as well.
Yeah, for sure. And the other thing I did was actually I got into running ultras, and so yeah, some common ground there, Andrew. I think I remember at one point after I ran my first 100 when I was 20 years old, I had a stress fracture of my tibia, and I actually remember going to the library at UCSF Medical School and pulling articles back before everything was online, and trying to read about stress fractures and reading about the whole physiology of how this is actually an overuse injury, not like a broken bone like you fell skiing or something. And I just found it so fascinating, and the whole process of diagnosing and treating an injury like that, I think was a pretty big part of my decision to go back to junior college. And I mean, so that was a big deal for me, because I'd been living half the year every year up in the mountains climbing and running, and like the idea of being in school in a city for 3 months at a time was almost unimaginable to me at that point in my life. But I decided to take a class in anatomy and at the junior college, and that was it. I was like, okay, I love this. Yeah, it's challenging, but I've done challenging before, and it's really engaging and interesting, and I think that was probably what set the hook.
It's very interesting. We do have a lot of similarities as far as the running goes, and An anatomy class actually was one of my first introductions into medicine, which came after a stress fracture in high school. And so it's interesting. I'm curious, we'll have timestamps on this, and so people who are not runners can skip past this right away. But I'm curious, when you said your first 100, was that 100 miler or 100K?
100 miler. Well, 100K came first. This was, so what it would have been 1983. I ran a 50K, then I ran a 50 miler. Then I ended up getting into the Western States 100 through the lottery, which even back in 1984, there was a lottery. It was a popular race. And then I ran 100K in training for that, which was really hard. And then ran the Western States in '84. It was my first 100 miler.
I can't believe you did the Western States. That's insane. That's a really difficult race.
It was, but you know, you think of that the same way you think of medical school. It's like it's long, it's challenging, it's hard, and if you look at the whole thing, like if you're looking at the finish line the whole time, you're going to feel like you're never going to get there. But if you look at each step, you know, you just work your way through it.
That's true. Marathons, that's a really great analogy. People oftentimes like compare marathons to medical school, and yeah, it's probably more like ultras. But anyway, that's really interesting insight into it. And I'm happy to speak to a fellow runner as well. I'm training for 100K in June. So.
Oh, I look forward to hearing about that. Well, we'll have a few minutes after.
Sure. Yeah, that would be
have
great.
to bore your class with that.
Yeah, getting back to things. So you have some experiences after dropping out of school in the great outdoors that teach you, hey, maybe this is something I want to investigate. And so I'm curious, for undergraduate education for you, what do you believe are the 3 most important things that a pre-med student can and should do during their undergraduate years of education?
Yeah, I really think it's important to follow your interests and not let your pre-med aspirations dominate your experience of being an undergrad. When I look back on my undergrad years, I decided to be a biochem major, but I actually was probably more interested at the time in history and English. You can do your pre-med classes and you can still major in something that has nothing to do with medicine. And it's one of the last times you're going to have a chance to do that. And I actually say nothing to do with medicine a little bit tongue-in-cheek, because the fact is medicine is about humanity. Medicine is about people and about
much later.
And so, I would argue actually that, anything you do in your undergrad years is just as important to your medical career as the sciences are. And you're going to take enough sciences for just your core prerequisites as it is. So follow your interests. And also be engaged in that time. It's so easy to just have your eyes focused on that future goal of getting into medical school, and to kind of view the undergrad years as a stepping stone. I think it's natural and maybe unavoidable in some ways, but I think to the extent you can discipline yourself to engage in the here and now and really focus on what you're doing and get something out of every class, I think that's really important. I also think it's great to the extent that your time and schedule allows to get out and have some volunteer experiences. It doesn't matter whether you're going out and doing some amazing international health thing in another country, or you're volunteering in the front office of a provider's office in your town. Really kind of just getting a sense for a little bit what this world is like is, I think, a good thing. And then I think the third thing is taking care of your health. It's easy to feel like what this requires of you is studying 20 hours a day and not getting any exercise and not focusing on your diet and not getting enough sleep, and that's all a big mistake. Sleep debt is cumulative. You'll have plenty of years to build up a sleep debt when you're in medical school and residency. Don't start now. Take care of yourself. Be healthy.
Yeah, I think there's a lot of pressure in undergraduate students with the very competitive climate that is around being a pre-med. It's something that we're trying to eliminate at Carroll PMC by fostering a sense of collaboration amongst our members. But it's quite hard. It's very competitive.
Much later.
Okay, great to have you back. We had to do a quick adjustment with the camera, and now we're a little bit more up close and personal, and hopefully audio doesn't cut out. Just reaffirming you can hear me, Dr. Wernham, right?
I sure can. Yeah, sorry about that.
Oh, it's okay. There's flaws in technology, and likewise, in my opinion, and Carroll PMC's opinion, there's flaws in immersing oneself in kind of the competitive atmosphere that can come along pre-med sometimes. And I'm curious just your insights. I don't know where exactly you got your undergraduate education, but I'm curious as to if there was a lot of competitiveness amongst pre-meds, and just the flaws and being competitive with other people instead of being collaborative with other pre-meds.
Yeah, I mean, I think I was fortunate in a couple of ways, but I strongly agree with what you're saying. So, you know, like I said, I took an alternate path to getting back into college, and what ultimately happened is, you know, after that anatomy class, I went back to junior college full time. And in California, where I grew up, the junior colleges are a pretty amazing system. They allow you after 2 years to transfer into a UC school if you have a grade point average better than 3.0. So that's what I did. I did a couple years in the junior colleges and then transferred into UC Berkeley. And you know, the junior colleges are a little bit of a different environment. There were a lot of students kind of like me who were coming from, you know, previous careers and making a change. We had quite a few people who had immigrated from other countries and were already professionals and were just kind of backing up their experience with a US degree. So it was, and then a lot of people like me who maybe dropped out and are not done well in high school and were just kind of trying to get back into the game, but with a little bit more maturity and kind of, you know, focus on the important things. So I'd say the junior college years were, yeah, although challenging and somewhat competitive, not quite as cutthroat. Then you get to UC Berkeley, and it's certainly a competitive environment. And you're, you know, like every pre-med in the country at that point, you know, you're competing against a national pool of, you know, extremely motivated, competitive people. I think anything you can do to focus on what's important, which is not that competition. It's why you want to do this, why you care enough to you know, go into medicine, you know, who you are as a person and what you're going to bring to healing other people. Those are what's important. The competition is really, you know, it's a means to an end, and probably most of us naturally overemphasize this sort of, you know, competition aspect of needing to perform well enough to get into medical school. You all at Carroll College are not competing against each other. You are, you know, needing good grades like every other pre-med in the country. But that's not what's important. What's important is you know, is bringing kind of who you are and why you care about this field into the profession.
I think it's so essential for any pre-med to just highlight the unique aspects about who they are. I think we can get caught up in the successes of others, and I think that's futile to one's own path. Not to get into running again, but it's almost as if you try and do someone else's race plan to try and run your own race. Like you need to run your own race. You got to do like what you're passionate about, and allow that to carry you through the exploration of medicine. That's something we promote here a lot, and I really like the way that you said it. And I'm sure there was plenty of competition at UC Berkeley, and so that's good that you were able to pull through with that. Now, I'm curious. I don't know when this started, so I might be jumping the gun a little, but I know you have a passion for public health. And so did that develop before or after you applied to medical school?
Yeah, it's interesting. I think it probably developed along the years that I was in, you know, in college, being a pre-med. I think I always had a, kind of a broader interest in humanities. Like I said, I was biochem major, but I think a lot of the most interesting classes I took were more history and literature and things like that. And it kind of explored the more, the broader dimensions of human health and well-being. So I think I was probably always oriented that way a little bit. I will say that the medical school I went to was a little different. So I did, the way it worked is I went to the UC Berkeley, UCSF joint medical program, and it's a 5-year program where you spend the first 2 years of medical school plus an additional year at UC Berkeley. And that additional year is focused on getting a master's in anything health related. And each student in the joint medical program puts together their own master's. A few of them did more bench science kind of research stuff. A lot of us did much more sort of humanities work. And I ended up working with the Navajo tribe and sort of looking at the interplay between culture and health and well-being. And that is clearly where I think I learned more about what health is in those few years than I had in my previous 20-some. And I think that's really where my passion for public health started.
Oh, interesting. And we're going to get into that a lot. But first, we got to get you into medical school. And so you ultimately went to the University of California School of Medicine in San Francisco. That's very interesting with the master's as far as that goes. I'm just curious if you reflect on your MCAT and your application experience really quickly before we get into medical school then.
Yeah, well, I mean, I will say, so, I think I had a decent GPA going into, the pretty competitive GPA going into applying for medical school, but I had also messed up like a couple of my prereqs. Like I think I had a C+ in one of my physics courses and maybe a C+ in one of my OChem courses. And there are plenty of people who would have told me, and even did, like, good luck. Like, you're not getting into medical school with that. Well, I did. I got in, I applied around the country. I probably applied to, 15 or 20. I knew that I had to do well in the MCAT, so I did a Kaplan course, and I mean, the course itself was fine. It gave me some good tips, but I think what I really did with the Kaplan course is I spent like all summer, if it was summer before the MCAT, just taking practice tests and practice tests and practice tests. And by the time I got to the MCAT, like I felt like I'd seen all the questions before. And so I had a very good MCAT score, a pretty good overall GPA, and some real misses on some of my essential prereqs that we're all told like medical school cares about so much. So I didn't know what it was going to be like. And, I think I had like, to one of your earlier points, I had focused through my whole life on, more about who I am than being a pre-med and being competitive and getting into medical school. And so I had a lot to say about who I was and my motivation for medicine that was, kind of beyond like those grades. I think that made a big difference. I think I got turned down outright from some of the competitive schools that really looked just at grades. The UC Berkeley, UCSF joint medical program is by the numbers one of the most competitive, but they look beyond grades. They really do look at who you are as a person. And so did quite a few other schools. So, I mean, I think I got offers from a number of the schools I applied to, but, definitely didn't have that sort of classic 4.0 A's in all your prereqs. It was not that student.
And usually there's no perfect applicant. Everybody's going to apply to medical school with some strengths and some weaknesses in some areas. I think by virtue of the interview process, by many pre-meds being almost like a coffee shop conversation like we're having right now, where you just talk about common interests and you speak kind of just human to human. I think that emphasizes that this whole process isn't just about the MCAT and the GPA, but it's about being holistic as well. So I'm glad you highlighted that. And so I'm curious if we got into, so we're getting into, you're in medical school now. Usually I ask guests on here a little bit more to inquire about just what they learned from medical school, some experiences. However, I'm interested in what medical school did not teach you.
It's a really great question. I think there's so much. I mean, I think you can run down the list of obvious things that are important, that are frequent criticisms of medicine. So we don't get enough nutrition education. And that's really, really true. A lot of the diseases that we're involved in managing, especially in primary care, diabetes, high blood pressure, heart disease, these are diseases of behavior, diet, and exercise. And so learning, having a stronger foundation in those things is incredibly important. But I think much more important, I don't think that medicine taught me very much at all about addiction, which is one of the most prevalent, most important chronic illnesses. It's underdiagnosed. It's behind a lot of the diseases that we do try to manage, like diabetes and high blood pressure. And so many people are struggling with some form of addiction. And I think just learning a constructive approach to dealing with that, whether you're an ER doctor, a primary care physician, even a surgeon, just learning how to make that a part of what's in the room with you and your patient is, I think, incredibly important. Going broader, I think what I've then learned for the rest of my career is just the degree to which health is not about a 15-minute office visit. Health is about everything else that person is experiencing the rest of the year, every day, and the rest of their lives. So, health and well-being depend on your income, on the house you live in, on your ability to transport yourself where you need to go, on the job that you have, on so many different factors that we can't control in a doctor's office. So, I think really what you don't learn in medical school is partly just, so how do we build a system around that? How do we build a system of care that's actually going to effectively help people through some of the barriers to health that are beyond what you can really deal with in a 15-minute office visit?
Yeah, it's hard to address all of that in quick amounts of time, but oftentimes doctors are pressed to have these visits, to see more patients, to go have a more of a turnover rate, which is awful to say about patients, but at the end of the day, a lot of settings, that's what it's about then. And it sounds like you're alluding to a lot of principles of family medicine in this. And so I'm curious if there were any experiences, much like the experiences that pushed you towards pursuing the specific masters you pursued, that put you on the family medicine path.
Yeah, so I think that it was interesting for me. I think part of it is I loved most of what I did in medical school. I mean, I really enjoyed pediatrics. I really enjoyed the family medicine rotations themselves. I liked the idea of continuity clinics where you had developed long-term relationships with your patients. And I liked having a relationship with the whole family, not just one age group. And I loved surgery. I liked delivering babies. So there, family medicine to some extent is a reflection of, here's one field where you don't necessarily have to make that much of a choice. But it's also, I think, a reflection of a value that just became clearer and clearer to me over the course of medical school, which is that trying to help people be healthier, trying to help cure illness in a setting that is divorced from people's whole experience, from their family, from their community, is challenging. We absolutely have a need for specialists, but I'm clearly not a specialist at heart. And I think really, the joy for me was in getting to know people in the context of, in that broader context.
And it sounds like you did, because before becoming the Montana Healthcare Foundation's Chief Executive Officer, you spent over a decade in clinical practice working in underserved communities in California's urban and Alaska's rural areas. And so I'm interested if you could elaborate on those experiences a bit, and in doing so, describe the similarities and differences you found working in those rural and urban areas across the country.
Yeah. It's really interesting. I mean, I'd say there are more similarities than differences. Definitely one of the things I learned is in those communities, these are communities, where, people are struggling against many of the same barriers, against, low income employment or high unemployment, against lots of sort of chronic social stress and a high prevalence of trauma, childhood trauma that people bring into adulthood and carry with them. At the same time as, I found, these communities in both places to be among the most resilient of any I've worked with. So many of these individual people who, if they tell you your life story, you're gonna cry. It's like, that it's just so much hardship. But at the same time, who they are is, amazing, dynamic, strong, intelligent, insightful people. And I think, also I think that common ground both communities shared was just a remarkable sort of intergenerational connection with family. So where I think a lot of us, kind of who end up in medical school grow up in communities where there's maybe, a little more focus on the individual, maybe a little less focus on family. A lot of the communities I worked with and took care of, family was still, the dominant force and the priority for people. People still lived in multi-generational households often, and just had a, remarkable strength of family and community. As far as differences, working in rural Alaska, you don't have as much, access to medical technology or specialists. So you kind of have to learn how to practice without some of the tools that you may have grown up with. Most of us train in larger medical centers, with some rural experience perhaps, but once you go out into a more rural region, it's harder. You can't just snap your fingers and get an MRI, or snap your fingers and have a cardiac consult. You have to kind of decide, what can I manage myself? Do I need to call an airplane to medevac this person to a specialty center, or is this something that we can stabilize and address or diagnose here? So I think just kind of learning to practice with a different set of tools was probably one of the main differences.
I think a lot of people speak to family medicine around the autonomy around patients. I think autonomy is a topic that a lot of doctors are concerned with during their practices. We've had a lot of family medicine docs on who have done some experience in rural areas, and they speak to the greater autonomy in rural areas over patients and over different procedures that they can do, simply by virtue of the lack of health professionals in the area that can do these things. So as a family medicine doc, you are oftentimes the OBGYN doc and the ER doc and et cetera of the community. Did you see autonomy, similar trends in autonomy in rural Alaska compared to being in maybe an urban center in California? Maybe the urban area was a little bit more less on your autonomy. I'm curious what your experience is.
Well, it's interesting. So, I mean, I think there's also a West Coast, East Coast difference there. I think there are more family physicians in communities around the Western U.S., not just the coast, who have a more autonomous or independent or full spectrum family practice. It's maybe seems a little less expected for me, for example, that family practitioners will be still, seeing prenatal patients and even delivering babies and even doing C-sections in the higher density population Eastern areas of the country. I trained in a residency in the San Francisco Bay Area, but it was actually one that was at the time kind of known as one of the couple in the country that really trained family physicians to do full spectrum practice. So it was an interesting county hospital in Martinez, California, that was basically all the specialty departments were run by family physicians who'd been doing that specialty since their residency. So we had an ICU run by family physicians, an ER run by family physicians. The OB practice had, was and GYN practice was mostly family physicians, and all of these were people who'd just been doing that for a long time. So it was an unusual program, and one that really did teach family physicians to be comfortable with a pretty full spectrum of inpatient and outpatient practice, and doing, you know, the simple surgical procedures well.
It's very interesting. I'm curious, two things based off of your experiences practicing. Just two questions. Number one, how do you believe current and future providers should go about battling addiction, which is often something that you can't see manifesting directly in somebody, but you get subtle cues based off of multiple different symptoms and aspects of their lives? How do you believe the future, what do you think the future is of addiction medicine?
Yeah, well, I think what we spend a lot of our time doing at Montana Healthcare Foundation is trying to do what I think of as activating primary care to be front and center in addressing the problem of addiction. Right now, we know that more than 90% of Montanans who probably have a diagnosable substance use disorder are not getting into treatment. And I think I draw an analogy to high blood pressure. We know that we care about high blood pressure because it causes heart disease, but we don't wait to do the first blood pressure check until somebody shows up with an myocardial infarction in the ER. We check blood pressure at every visit. You walk in, you expect to have someone put a blood pressure cuff on your arm. You expect the primary care doctor to attempt to manage that blood pressure. And diabetes is similar. We screen people, you know, very routinely for blood sugar and make sure they don't have diabetes. If they do, the primary care provider starts out managing it. When that disease gets more complicated, when the high blood pressure gets hard to manage, or the patient has complex cardiac complications, or the diabetes is you know, simply not getting better, we send them to a specialist. And I think we've not approached addiction that way, but it is what we should do. Addiction is just another chronic medical illness. It's something that, like diabetes, may wax and wane. You'll learn with your diabetic patients that it's partly physiology they can't change. It's partly, you know, behavior that you would like them to be able to change, that results in being able to control adult onset or type 2 diabetes. But you know, it's complicated, and every patient you'll see that their blood, you know, some of them it's just easy to control, and some of them have a really hard time getting, you know, a handle on it, and may have it controlled for a while and then fall off their diet, and then they're back to being in a more dangerous situation. I think addiction is the same. We should just be thinking of it the same way. You know, we've got probably, you know, prevalence of 10 to 15% of adults who step into a Montana primary care practice have an underlying problem with a substance use disorder. But if we're not screening for it, we're not able to even take any initial steps to manage it. And if we're not trying to do that, we're missing a lot of opportunities. And those patients, they're going to be struggling with their blood pressures and their diabetes and their high cholesterol and their diet too. So if we don't get a handle on the addiction, we're less likely to be able to improve those other problems as well. Wow. So I think it's essential. I think it's a primary care diagnosis, and I think it's one that you know, we should be involved in screening for, identifying and providing early treatment, and then when we need a specialist involved, we refer the patient just like we would for any other condition.
Right. It's got to be very hard too in settings when you're first speaking. Well, when you're speaking about these issues in general, and they're opening up, patients are opening up about their personal stories and personal struggles with addiction and other aspects of their life too. It's got to get pretty hard and pretty emotional very quickly in settings, and I think that a trend. At least in EMS, where I'm an EMT, but also a trend in a lot of settings, is that you should really be a stoic to some of the difficult things that you see in settings. And I'm curious what your opinion is on the aspect of being around patients and hearing their stories. And you mentioned earlier stories and events that you quite easily cry about. Do you think it's professional as a doctor to cry in front of your patient?
Yeah. I think it's a really hard question, Andrew, and I think that if that's a regular occurrence, you certainly need, you know, to probably be seeking some guidance yourself and just sort of figuring out what that's about for you. But I think that you know, if you find the right path, you can be engaged and empathic, and care deeply about your patients, but at the same time, not become sort of unmoored from the therapeutic relationship that you need to have with people, which I don't think it means being insensitive, being cold, being, you know, appearing detached. But I think that it does mean being able to maintain your own sense of groundedness, being able to maintain your focus on what this person needs to get better, which may be empathy in some cases, but it may also be, you know, a detached, objective perspective. So I think as long as you're able to sort of monitor yourself, to have really good self-awareness in your interaction with people, you know, I think that you can bring, you know, that full spectrum of engagement and empathy, as well as sort of therapeutic detachment and objectivity that you need to every clinical interaction. Most of us are going to encounter cases where it's really hard not to cry, and I think in some of those cases maybe it's appropriate. But I think that is, I think it's challenging, and I think that there are probably times, and probably most of us who've been in practice for a while can think of times where you wish you'd been a little bit more sensitive and more engaged and shown more of yourself, and also times where you feel like maybe that was a little too much for that patient, maybe that overwhelmed them. So
Yeah, well said.
Nuanced. I don't think there's an easy answer.
There never is an easy answer. Okay, so I'm curious, how did your medical degree strengthen your ability to work as a policy advisor for Alaska and Native tribes?
Yeah, it's a really interesting thing. I think that a lot of us in clinical practice very naturally become so immersed in just the day-to-day challenge of trying to do a good job diagnosing and managing the medical illnesses that we're, you know, that you see. I mean, in an average day in primary care in Alaska, I would, you know, get up at 5 in the morning, go to the hospital, round on inpatients, get to clinic by 8, see 18 patients maybe on average every day. And then in the course of that, maybe be fielding calls from the hospital on my patients who are inpatient, or running back over to manage someone in labor. And so you're, you know, just those sort of fine-grained details of just trying to do a good job of the basics. It's you know, it's really overwhelming. But if you go home sometimes and you think about, like, what was hard, what was frustrating to me today, a lot of times you realize it's stuff that you can't do anything about in the office. I remember back to a kid that I saw when I was in residency, who he was 10 or 11. He came into the Children's Hospital in Oakland with his 3rd severe asthma admission in about 2 months. Each time he stayed in the hospital for like 10 days. He was missing a ton of school. His mom was missing a ton of work. And he would come in, he would get better gradually, and then go back out, and then a week later he'd be back in. You know, we wondered, like, is his mom just not giving him his medicines? No, she was super smart. She could tell you exactly which medicine she's supposed to give at what time, and and show you how she did it, and you know, so that was not the issue. But eventually, in talking to her, you know, she said, our apartment is just so horrible. It's got this ancient carpet. It's got mold all over the walls and in the kitchen and the bathroom. And I remember going to the attending and saying, you know, can I prescribe like a new apartment? You know, and of course the prescription pad doesn't work that way. The problem there is just one of housing costs and housing, you know, quality and maintenance. I mean, she couldn't afford anything else. So we were spending tens of thousands of dollars on this kid in the hospital to make him better in the hospital, where actually a better apartment would cost a lot less. That's the connection between what you know about, you know, kind of the connection between a patient's health and individual physiology and the world of policy outside the doctor's office. And I think so the very long-winded answer to your question is, I think what physicians have to bring to the policy world is being able to make that connection for people in a poignant, powerful way, being able to bring your scientific understanding of the factors that influence health and well-being from individual patients out into the policy sphere. So the work I did in Alaska was really about helping tribes find a stronger voice in a federal permitting process for oil and gas development, where and they were actually not advocating just purely against oil and gas development. It brought revenue that supported schools and a public health system in the North Slope, but it also brought new air quality problems near the reservation. It brought huge social change because you had a huge influx of oil and gas workers into these small, isolated Native communities. And all they were asking for was like, can we think about how to manage this? Can you help us think about, like, are there ways we could improve the air quality? Are there ways that we could monitor the impacts on our respiratory health from what we think are, our fumes coming from the oil processing facility just down the river from us? Can we think about how to manage problems like sexually transmitted diseases spreading in the community when you've got oil workers coming in? And what I was able to do was just sort of take that individual clinical understanding and help them think through, okay, how do we put this in a policy framework? How do we bring some science to it and help talk to these regulatory agencies in a way that is maybe going to help shift policy? And it worked because it was a combination of very strong community will. It was work that was grounded in the community's voice, and it was work that I was able to bring sort of a medical and healthcare professional lens to. Doctors are in a unique position to do that.
Yeah, I think having that individual focus on patients as a physician in clinics and having the background understanding of human physiology and science and knowledge about just being human, I think that can definitely help to individualize certain aspects of healthcare delivery to an individual, to a population community, and ultimately to the whole state of Alaska as well, implementing changes and policies that are going to impact this specific population. However, I think it's pretty hard to fathom extending that to an entire national coverage where there's just so much diversity and there's so many different areas that differ in policies state by state by state that I don't know, to me it sounds very, very, it's very it's daunting to say the least.
Mm-hmm.
And so I'm curious, how did you and do you continue to try and extend policy change and impact policy on a national level? And how can future prospective medical students and physicians plan on or think about doing the same in their careers?
Mm-hmm. Well, I think that the best of national policy filters up from real world experiences at the state level. I think of one example from a few years back in our work at the Montana Healthcare Foundation was, that Congress was considering major changes to the Affordable Care Act, and inside the Affordable Care Act is the ability for states to expand Medicaid to cover low-income adults. Medicaid expansion in Montana was a few years old at that point, was really just getting going, and it had a profound impact on nearly 1/10 of the state's population, providing for the first time access to addiction treatment, providing for the first time access to mental health care, to screening, to cancer screenings, to a wide range of things that we know will positively impact health. And Congress was sort of considering, basically wiping out the ability for states to expand Medicaid, which would have dropped, almost 100,000 Montanans from their healthcare coverage. And beyond that, it has impacts on the health system. We know that the states that expanded Medicaid, their rural hospitals and critical access hospitals are about 6 times less likely to close than they are in states that didn't, because it actually provides reimbursement for critical services that they're obligated to provide to everybody in their communities. So that's all a bunch of facts, but how does that translate really into policy? Well, you realize if Congress is voting on this, Congress is made up of individual elected officials from each state. And, and oftentimes the balance of policy hangs on a few votes. So, can any one physician, change a senator's vote or a congressperson's vote? Probably not. But can you provide facts and information and perspectives that are really critical to helping those elected officials or people, the appointed officials that run agencies that make a lot of rules that affect us, to understand the circumstances. What is this going to look like on the ground in Montana? So we did a series of reports that really looked at that. We worked with some provider organizations to do reports on individual patient stories of people who had received coverage under Medicaid expansion and what that had meant to their health and their families and their lives. We did reports on, that looked at statistics. We did a report that looked at the impact of Medicaid expansion on tribes, which for the first time, really in modern history, tribes with Medicaid expansion had, closer to the ability to sort of fully fund a health system for their people than they had ever had before. And so by doing all of that work and sort of trying to connect to a personal level, we're certainly able to at least provide, our state leadership enough information to reach a good decision. And so I think if you break down how national policy happens into sort of those individual situations and relationships, you realize that your voice, even though you may not save the day by yourself, but certainly your voice is going to do a lot more good being there than by not. So showing up is important.
Do you think it's difficult, or has it been difficult for you for your voice to be heard, since you're a physician and you're presenting science and facts, and unfortunately, oftentimes in today's climate, facts don't come across, and there's a lot of opinions and knowledge, or opinions and speech going around that aren't based off of scientific facts and knowledge. Do you find it hard for your voice to be heard as a physician?
Yeah, I mean, I think that the nice thing about what I'm saying about being a physician is you can sort of speak with a foot firmly in both worlds. And, you can speak from the science, you can bring epidemiology and public health data, population level statistics to bear. You can also, though, speak from your personal experience, individual interactions with real people, with Montanans. And I think by being able to bring both of those to bear, you have a better chance of reaching more people. I think there is no question. I mean, I would never represent that this is easy, nor would I represent that everything that we say results in the perfect actions that we would want to see happen in our health system. That's not the way it works. But I think that what we do really try to do with Montana Healthcare Foundation is contribute to a productive dialogue by bringing rational perspectives to bear on these debates, by bringing objective and hopefully credible data to bear in ways that that we're not trying to sort of downplay or dismiss other perspectives. We're just simply trying to kind of put information out there so that people can consider it. And I think when you do that in a way that kind of connects the statistics and the science to individual reality, and when you also bring those other skills you have as a physician, like listening to the conversation, what are people saying? What are these other perspectives that I might not agree with? Where are they coming from? And then having reasoned, objective conversations about those, I think you can still, even in this crazy environment, make a difference.
That's a beautiful way to put it, and it sounds like it's very impactful to be able to you're able to really use hone those skill sets that you learned in medical school for direct patient interactions and administration of medications and medical treatment in clinical facilities. And it sounds it sounds quite clear to be translated to the policy world as well. Clearer than I had originally thought, and clearer than I think most people would think when fathoming.
Yeah, and I mean, I make it sound good. It's not to say that you don't have frustrations day to day, just the way you do in clinical practice. I mean, the funny thing is, the same question you're asking about influencing policy, you'll probably find yourself asking as you go into clinical medicine, like, why can't I make a difference in this individual person's life? I know what they need to do. I know what needs to happen, and still it's not helping. And so I think, I think it's, if you're good at a provider, you'll learn all kinds of techniques of kind of like identifying what the barriers are to changing behavior and helping do motivational interviewing and other kind of skills that kind of help move people along in the right direction. And I think you can apply those to the policy world, but I think you're going to find in both settings that it never works perfectly.
Sure. Yeah, there's frustrations in that either side of the coin, and different ways in which you make impacts. And it's an interesting decision then to choose. You love science and you love helping people and you want to spread rational knowledge. You want to help people and connect people on an empathetic level and really harbor good connections to help as many people as possible. I think it's hard then to decide whether or not to do so from a clinical or a public health approach as a physician. So I'm curious, in your opinion, what demands to be attended to when making this decision? Do I impact the world as a physician clinically or through a public health approach?
I think one of the most important things to take from my experience is that you don't actually have to make that decision. I remember really torturing myself about this when I was trying to decide on what residency to do. I was pretty torn between doing a primary care specialty. I was pretty interested in surgery. I was torn, about going into more public health or preventive medicine. It was a really hard period and a hard decision. And I think when I look back on that, what I've realized is, it actually didn't matter. You can make those decisions step by step. You can decide what specialty you're going to be in. You can decide where you're going to practice, and you can always take everything you've learned up to that point and make a change if you feel like, I need a different direction to have the biggest impact to do what I really care about doing. So don't feel like you're set on a rigid track when you make these. When you make choices of specialties or choices of practice location or any of the career choices you have to make, you can bring public health back into it at any point in time. I was fortunate that the way this happened for me was, I'd been in clinical practice for 10 years. I'd been more and more and more attuned to kind of the kind of public health and policy level work that needed to be done to make my patients' lives better. And then there was this national fellowship, which is not active currently. I'm kind of hoping that it may get restarted, but it funded like 4 to 6 physicians a year from around the country, usually mid-career people, to do a fellowship in public advocacy and public policy. And you basically paid for half your time to go and do this work. So that was one way to change a career, but there are many. And I've had a lot of conversations just in the last few years, even with mid-career providers who want to make a change, and you can definitely do it. So.
That's great. So as the Carroll Pre-Med is listening to us and struggling on their journey, possibly sharing the same insight and interests in public health, but really just struggling to get past the MCAT, struggling to get past the applications and fearful for lack of interviews or the inability to just be considered as enough to get into medical school. What final words of wisdom do you have for them?
Yeah. It's really easy to get lost in that very natural anxiety about sort of, just getting to that next step, just applying and being and having someone accept you into this profession. I think what is the most important, though, is thinking instead from the perspective of what do you really want to bring to this profession and how do you develop that? So you came to it for a reason. You probably came to it for really good reasons that are things you really care deeply about. focus on those and focus on your day-to-day. Focus on getting the most out of a class instead of getting the best grade out of a class. Focus on, on learning the most about sort of, the people you want to help and sort of who they are and why you care so much. And also, recognize that, I mean, in many ways, the door is never closed. I've talked to plenty of people who got rejected on their first wave, even of applications. They did not get into a medical school, who then made it in. Either they went to nursing school and then reapplied, or they became a physician's assistant and then they and developed a full career there. I will never forget the first physician assistant that I met in medical school was a heart surgeon. I had no idea until after my first heart surgery that this physician's assistant had done a whole lot of the case without the actual cardiothoracic surgeon in the room. Not all of it, but there's an awful lot that you can do, and a lot of different paths to get into the world of kind of caring for patients and helping your community. And so just say, take it day to day and focus on who you are and not sort of that next goal.
And with that, we end another episode of Carroll PMC's video interview series and wrap up another story for you guys. I really enjoyed Dr. Wernham and I's discussion. I think it highlighted some aspects of being a physician and helping others that usually are clouded by the emphasis on the clinical side of medicine, which is very important and very rewarding and very impactful for many different people. However, I think it can oftentimes cloud the impact that you can make on a policy level as a physician, the impact that physicians have on governmental entities, on state entities, and other things that can truly help a lot of people. And as physicians, always aiming for the utilitarian aspect of medicine and ethics, the greatest good for the greater good. I think Dr. Wernham's experience has shed some insight into that. I really encourage you guys to look on our Moodle page on Med100 to look at some of the opportunities we've linked towards articles and websites about pursuing masters in public health, about pursuing different adjunct educations in addition to just your medical degree. There are people, like we spoke about in the meeting in, last fall, there are many different things you can pursue and learn and educate yourself on in tandem with your medical degree or your DO degree. And so I encourage you guys to seek out those opportunities. Like Dr. Wernham said, pursue your passions. Let your passions lead your way and lead your path to becoming a physician. Thank you for taking the time to listen and or watch me today. Hopefully this guy's helped you gain some insight into what it takes to become a successful pre-medical student. As always, if you have any questions, please consult with your Carroll PMC officers, schedule an office hour slot with myself on Moodle, or consult with Carroll faculty of your choosing. Have a great day, and I'll see you guys next time.